All right, let's jump straight into this explainer. Today, we're tackling high-yield, exam-facing clinical decision logic for infectious diseases. We're going to move system by system, pulling out the exact diagnostic and treatment pathways you absolutely need to know for your exams and when you're out on the wards. No fluff, just the high-yield facts.
Here is our roadmap. We'll be hitting neonatal and CNS infections, ENT and airway emergencies, genital urinary infections, cardiopulmonary management, and finally skin and bone deep tissue invasions.
Starting off with Section 1, Neonatal and CNS Infections, Protecting the Vulnerable.
Okay, let's talk intrapartum Group B strep prophylaxis. GBS is notorious for causing early sepsis, pneumonia, or meningitis through vertical transmission and later focal infections horizontally. So we routinely screen moms at 36 to 38 weeks. But here's the absolute clinical key you have to remember. We only give that IV penicillin during labor. If the mom's status is unknown, you've got to trigger prophylaxis for premature labor under 37 weeks, any intrapartum fever, or if the rupture of membranes goes over 18 hours.
Moving on to neonatal conjunctivitis. For this, the timeline is literally your diagnosis. If it shows up under 24 hours, you're looking at chemical irritation from prophylactic drops, just mild irritation. But if it hits at 2 to 5 days with this profuse, purulent discharge, that's gonococcal. You need to hit that with a single IM dose of a third-generation cephalosporin. Now, if it's 5 to 14 days out and you see a watery or mucopurulent discharge, that's chlamydia, which requires oral erythromycin. The exact days really matter here.
Now, when it comes to empiric meningitis coverage, age entirely dictates your regimen. Newborns are tricky. They often don't show those classic meningitis signs like nuchal rigidity. Instead, they'll present with hypothermia, poor feeding, or apnea. You need to evaluate them with blood, urine, and CSF cultures, and then start empiric ampicillin plus cefotaxime. And listen closely to this. We explicitly avoid ceftriaxone in neonates. Why? Because it displaces bilirubin and causes kernicterus. It's a huge board trap. For older infants and adults, where strep pneumo and N meningitis are the main players, you're going to switch over to vancomycin and ceftriaxone.
Section 2, ENT and airway emergencies, Securing the passages.
So for suspected streptococcal pharyngitis, you're going to rely heavily on the CENTOR criteria: fever, tender anterior cervical lymphadenopathy, tonsillar exudates, and the absence of a cough. If they have 0 or 1, no testing. If they hit 2 or 3, trigger a rapid antigen test. But if they hit all 4 criteria, you go straight to empiric treatment with penicillin or amoxicillin. And keep in mind, this exact same Group A strep can present as scarlet fever. So be on the lookout for the addition of a strawberry tongue and a rough, sandpaper-like rash.
Now, if you have a child with rapid onset of fever, a muffled voice, and they're drooling, that helps you immediately differentiate epiglottitis from something like croup. Lateral neck imaging is going to show that classic thumbprint sign from an enlarged epiglottis. This is a massive red flag for impending airway obstruction. Your #1 priority, secure that airway right away. Only after that do you start IV ceftriaxone plus vancomycin.
How do we differentiate a simple tonsillitis from a peritonsillar abscess? It really comes down to the hot potato voice and trismus, which is when the patient literally can't fully open their mouth because of muscle spasm. If you see trismus, unilateral swelling, and uvular deviation, you've confirmed an abscess. And here's the kicker. Antibiotics alone just won't cut it. You have to follow up with a mandatory needle aspiration or an incision in drainage.
Antibiotic stewardship for ear pain is all about identifying active inflammation. Acute otitis media is going to present with a bulging tympanic membrane and visible pus. That gets a 10-day course of high-dose amoxicillin. On the flip side, otitis media with effusion just shows fluid behind the eardrum, but without those active inflammatory signs. If it's just an effusion with no inflammation, strictly observe it. Don't throw antibiotics at it.
But what happens if that acute otitis media goes untreated? Well, it can spread right into the mastoid air cells. You should suspect mastoiditis if you see fever, post-auricular tenderness, and the auricle is actually protruding outward. Once you confirm opacification on a CT or MRI, IV antibiotics are absolutely required. And your regimen has to include vancomycin for robust gram-positive MRSA coverage, plus you'll need surgical drainage.
Section 3, genitourinary and renal infections, following the flow.
For UTIs, our antibiotic selection shifts strictly based on severity. Uncomplicated UTIs get targeted lower tract agents. We're talking nitrofurantoin or phosphomycin.
But the second you see systemic signs, like pelvic pain in men, back pain, or a fever, you're now dealing with a complicated UTI or pyelonephritis. This requires a big step up to broad gram-negative aerobic coverage using outpatient fluoroquinolones or inpatient ceftriaxone. And you only adjust that coverage after you've obtained a urine culture.
Pediatric UTIs are a bit different. They follow a strict cascade to prevent long-term renal scarring. After you confirm the infection, any child under 24 months who is having their first febrile UTI absolutely needs a renal and bladder ultrasound. Now, if that ultrasound reveals anatomic abnormalities, or if the child keeps getting recurrent UTIs, you have to proceed to avoiding cystourethrogram to check for reflux.
Section 4. Cardiopulmonary infection management, lungs and valves.
For patients with hyperinflated lungs from COPD, exacerbations are unfortunately super common. But antibiotics are strictly indicated only if the patient has increased sputum purulence, increased sputum volume, and increased dyspnea, or, of course, if they require mechanical ventilation. In those cases, you're going to rely on macrolides or respiratory fluoroquinolones to cover atypical organisms and stop any further respiratory decline.
Infective endocarditis prophylaxis is highly targeted. We don't just hand it out. High-risk procedures that involve manipulating gingival tissue or actually incising the respiratory mucosa? Yes, those require amoxicillin prophylaxis. But routine GI or GU endoscopies, or most vaginal deliveries where there's no active infection, those are low risk. No prophylaxis is needed at all.
Let's say you're treating infectious endocarditis medically with IV penicillin G or ceftriaxone, but it fails to clear. You have to recognize the indications for surgery. If the infection extends into a fistula or an abscess, if you're dealing with multidrug-resistant bacteria, persistent bacteremia, or if you see large vegetations that are causing acute heart failure or sending off septic emboli, surgical intervention becomes completely mandatory.
Section 5. Skin and bone infections, deep tissue invasions.
For vertebral osteomyelitis, a patient will usually present with focal tenderness and elevated inflammatory markers. MRI is going to be your most sensitive imaging modality here. But here is the absolute golden rule. Unless the patient is hemodynamically unstable, you must hold your broad-spectrum antibiotics until after the bone biopsy is completed. Once you've got that biopsy, then you treat empirically. You want IV vancomycin to cover MRSA, paired with an anti-pseudomonal beta-lactam like cefepime to cover potential Pseudomonas.
It's really interesting how superficial fungal infections often set the stage for deep bacterial invasions. In severe lower extremity cellulitis, chronic, non-invasive tinea pedis is actually an incredibly common culprit. The dermatophyte creates fissuring and erosions right between the toes. This breaks the skin barrier, essentially rolling out the red carpet for invasive strep or staph to enter the deep tissue.
Visual identification of superficial infections is key because it dictates your coverage. Take bullous impetigo, for example. It presents with these flaccid bullae filled with yellow fluid. When they rupture, they leave behind a characteristic collarette of scale. Seeing this presentation demands immediate, targeted gram-positive coverage with agents like cefazolin or clindamycin.
This next one is a classic exam mimic. You need to differentiate a local allergic reaction from a true bacterial infection. If a patient comes in with an exaggerated, warm, contiguous swelling following a bee sting that developed within 24 hours, that's an IgE-mediated allergic response. You treat that with cold compresses and steroids. Bacterial cellulitis, on the other hand, takes 3 to 5 days to develop and usually spreads asymmetrically from the wound. Timing entirely dictates your management here.
All right, let's do a fast recap of the highest yield clinical distinctions we covered today. 1. Use cefotaxime, not ceftriaxone, for neonatal sepsis to avoid kernicterus. 2. Treat streptococcal-pharyngitis based strictly on center criteria to prevent rheumatic fever and always check for scarlet fever signs. 3. Always secure the airway before giving antibiotics for epiglottitis. 4. Uncomplicated UTIs get targeted lower tract agents, but systemic signs demand broad-spectrum IV coverage. And 5. Always hold antibiotics for stable osteomyelitis until a bone biopsy is secured. Know your timelines, recognize the mimics, and understand your coverage.